Okay, so we're going to finish up. Let me just turn the lights. So let me just start over because I just only started at the very beginning of the last. But chapter 22, we're going to talk about obstructive pulmonary disorders. So with this, we're basically talking about the chronic obstructive pulmonary disorders. So again, COPD stands for chronic obstructive pulmonary disorders, and under these disorders will include asthma, chronic bronchitis, and also emphysema. We will also go over acute bronchitis, but that doesn't fall under this category. Okay. And again, when we talk about obstructive pulmonary disorders, please make sure you understand that anything that's obstructing the airway, where air or ventilation is not successful. Okay. So, let me just go here. The first one we want to talk about is asthma. Asthma, what happens here is what you should understand with asthma, and not only just asthma, but most of the respiratory conditions, is that it's an immune process or immune response that occurs that causes this obstruction, okay? So what happens here with a person that's asthmatic, as you know, most of the times people that have asthma have some sort of allergy, okay, or something that's triggering this. So say, for example, a person, yes, immune response. So say, for example, a person that has asthma that is maybe allergic to, say, cat hair, dog hair, or, sometimes people that are asthmatics, they can't have carpet in the house because, the dust and everything that just will trigger it all. So what happens here is that when these individuals do have an allergic reaction to that particular allergen, whatever it may be, it will cause a bunch of immune cells and everything to get pretty much exacerbated. I call the term exacerbated, but what it really is, it's a hypersensitivity. So these individuals have a hypersensitivity to a particular allergen. And when that hypersensitivity reaction occurs, they will start to release a whole bunch of immune response or immune inflammatory. I'll explain it again. I'm kind of bad at this moment. But what will happen is the immune response will get set off, okay? So what will happen is that they will start to secrete mucus and a bunch of immune cells, and everything just kind of clogs up the airway because it's trying to get rid of that allergen, but it's causing an issue, okay, by clogging up the airway. Okay, and I'll go over that again, what I've just said. So the etiology here they have is the obstruction of airway obstruction that is reversible, okay, not completely in some patients depending on the severity of the asthma. Airway inflammation, please make sure you highlight that because it's really an inflammatory type of process that occurs with these individuals. An increased airway responsiveness to a variety of stimuli. So what does this mean? This means that the immune system will get kicked in once they come into contact with that stimulus, whatever it may be, whether it's the cat, the dog, okay, dust, cigarette, whatever it is. Now, they give you some stats here. Occurs 5% to 12% of the U.S. population. This is the most common chronic childhood disorder. Okay, so please make sure you know that. And they give also the high-risk population. What happens here with children with asthma? When a child's immune system starts to develop, and when the immune system is developing, they will start to develop this hypersensitivity at that point, okay? So what child will know, well I shouldn't say the child will know, but the body will know at that moment if it is going to be type 1 or whatever type of hypersensitivity, okay, because of the immune system process that's going on at that point. Now, some predisposing factors. They do have a genetic for atopy, and I'll explain what that is. Atopy, if you want to jot this down, just means an immediate hypersensitivity reaction. Atopy stands for immediate hypersensitivity reaction. And they give you here the actual chromosomes. Okay, so this shows you right here, and we know how people say, oh, asthma runs in my family, and so yes, this is genetically tested, and so they give you here the chromosomes 5, 11, and 14. Those are the chromosomes that will have that genetic information that will show that these patients do have this specific, particular type of hypersensitivity, okay, which is the atopy. They also could have a history of hay fever and eczema. Now, not to say that everyone that has eczema will have asthma, but sometimes it kind of goes hand in hand because eczema also falls under that category as a hypersensitivity type of reaction. Family history, as we just talked about, and also people that are positive skin testing to certain allergens. One thing that's very important, and I'll see this with some of the testing, not only just getting blood work done and looking at what's going on with the immune cells, but also a very good test for these individuals is to make sure they have allergy testing done. Okay, because what will happen is, in order to control the asthma, yes, you can control it with bronchodilators and all that stuff, but you have to treat the cause as well. So if it is a known allergy, it is best to know what the known allergy is so they can stay away from it. Okay, so just keep that in mind. Now, they do have what is called the extrinsic or allergic type of asthma. Now, this is the most common type. They do have another type called the intrinsic type. The intrinsic type, if you want to jot this down because it's not on the slide, the intrinsic type does not have a known cause, but it happens in individuals that are over 40. So when people get an adult type of onset of asthma, that's usually more of the intrinsic form. Okay. But in any case with asthma, even if it is the intrinsic form, so say for example someone 40 years old starts to develop asthma for whatever reason, it could be also an allergic situation that's attached to it, okay? But usually when we're talking about childhood asthma and more of a young adult, or children, this is the extrinsic form, okay, which is definitely a known allergy, whether it's pollutants or whatever type of cat hair, dust, whatever it may be. Please also highlight too that this is an IgE-mediated response that is common with these individuals. So when we talk about the immune process that's going on with them, they will have the immunoglobulins E, okay, that will be secreted. Okay, in this type of allergic because it is an allergic reaction that occurs. So IgE. The other thing here, along with elevated IgE levels, they will have allergic rhinitis, okay, which just means a runny nose. Eczema could be possible. Also, positive family history of allergies. Sometimes allergies do run in the family, okay, so even if the mom or dad does not have asthma, so to speak, but if they have other types of allergies, it can also predispose that child to having not only just an allergy, but also to certain asthmas or asthma. Attacks can be seasonal, environmental, or occupational. Please understand that sometimes with asthma, yes, it is a known allergy, but sometimes it could be a person's work environment, so maybe they're working around dust. Also keep in mind too that their exercise-induced and stress-induced asthma also fall under this category as well.
Exercise and what?
Exercise-induced asthma and stress-induced asthma. So sometimes when individuals are in stressful situations, as you know, the immune system is, definitely activated at that point. Also with exercise. Sometimes when individuals do, say, I don't want to say just a regular exercise, but do have to recover, their bodies are trying to recover from maybe a hard workout or trying to do muscle repair or something of that nature, the immune system can also get activated, okay, and then cause this type of situation. Okay, now, we're going to break down, and I think it breaks it down in like maybe 5 different slides, okay, the pathophysiology of asthma, okay, so it's quite long, but it's not that hard to understand. So, what happens here, the immediate phase. So say, for example, an asthmatic patient comes into contact with a cat, and they're allergic to cat hair. And so what will happen here is that when they do get exposed to this, initiated by exposure of a specific antigen that has previously sensitized mast cells in the airway. So the body will actually now start to get sensitized to that particular allergen, okay, whatever it is, cat, dog, whatever. The antigen reacts to the antibody on the surface of the mast cell, and the mast cell will release these chemical mediator substances. So what will happen here is that those mast cells will now start to secrete chemical mediators, which we know from physiology chemical mediators will now start to attract more immune cells come into that area. So this starts the immune process. That's the immediate phase. Now, chemical mediators that get released, and some of these you guys may know already. I'm not going to go through each and every one. I'll just kind of talk about histamine. Histamine, we have leukotrienes, prostaglandins, bradykines. Does this sound familiar? Okay. So all of these chemical mediators will be released, which means we definitely have an immune situation that's going on. So say, for example, histamine. Histamine is released, and when histamine is released in the body, what happens? Do you know what happens physically to the body when the body has a release of histamine? There are some signs and symptoms that come from the release of histamine.
Hives?
Constriction can happen in the airway. What else? What are some physical signs and symptoms that happens when you're allergic to something?
I got like runny nose.
Runny nose, sneezing, itchy eyes, watery eyes. All of those physical findings get released from the release of histamine. Now, the reason for that is because when these chemical mediators are released, it will send a signal to make all of these manifestations happen in the body to let you know that you are allergic to this particular allergen. Now, we take an antihistamine to kind of suppress the symptoms, but to feel comfortable, but the whole process of the histamine release is natural, and it's supposed to happen so you will know that you are allergic to something. So keep in mind that this is the reason why these chemical mediators are released. Okay. This diagram here, I'm not too crazy about it, so you don't have to worry about that. Too much going on there. Now, another thing that happens here, it says normal respiratory epithelium is denuded, meaning that stripped, and replaced by goblet cells. What do you remember from anatomy? What is the purpose of goblet cells?
Secretion of mucus.
Secretion of mucus, very good. Now the respiratory tract has a certain amount of goblet cells, but not a large amount. Now, why do you think that we would have goblet cells secreted or secreting mucus in the respiratory tract? What is the purpose of mucus being in the respiratory tract? To catch, very good, to catch any type of, I don't want to say microorganisms or allergens or whatever type of harmful material that you're inhaling. So what happens here is that because these individuals are going through a hypersensitivity reaction, the body's just going to go crazy and now just strip the respiratory epithelium and now have a large amount of goblet cells on the respiratory epithelium, which means they're going to have a large amount of mucus that's being secreted to try to trap all of the allergens that they're inhaling. The problem is, that's a good thing, but the problem is that we have so much mucus in the airway that now we're causing an obstruction. Okay? So just keep that in mind. This is the physiology of it, but it's an issue. Okay, so we need mucus, but not that much. Okay, so but the problem is because it's a hypersensitivity, it increases more mucus than it should. Now, the other thing that happens here is that we do have mucosal edema. So what will happen now is because of the inflammatory process, we know that when the inflammatory process occurs, we start to secrete certain exudates of fluids. Okay, does that sound familiar? So remember that certain fluids are secreted during the inflammatory process. So not only do we have mucus that's clogging up the airway, but now we also have fluid. The other thing that's going to happen here is bronchoconstriction. So when the body is in response to, say, whatever type of, I don't want to say immune process or something that is not flowing properly or shouldn't be introduced into the body, the compensatory mechanism is to do this. Okay, I think we talked about vasoconstriction when we talked about vascular system. Okay, so what's going to happen is the body's going to recognize, hey, we have too much, stuff going on here. So instead of dilating, it's going to now constrict. And when it constricts, this also causes a decrease in airflow. Okay, so keep in mind, so far we have mucus, we have edema, and then we also have bronchoconstriction. The leakage, I'll explain in a second, but the leakage comes from the capillaries. What will happen here is because these individuals are going through an inflammatory process and the gas exchange does not happen properly at the capillary level, that they'll start to leak fluid. Okay, so they'll start to leak fluid and have more edema actually at the capillary level.
This leakage happens because of leakage due to what?
Leakage from the capillaries. So what happens is the inflammatory process increases more fluid, and at the capillaries, remember that this is where we have not only just gas exchange but fluid exchange. So now they're leaking more fluid from that capillary level. So late stage here, what will happen is leukocytes will come to the area because that's what they do. So say for example, what is one leukocyte that you think is going to come? Neutrophils, and what's another important one? You're right with neutrophils, but what's another big important one? Macrophages. Okay, very good. Somebody said it. Macrophages. Keep in mind that macrophages, as you know, I call them like the little Pac-Man cells, and they just try to come and eat and get rid of whatever the problem is. But the issue here is, as these macrophages come to the area and they're trying to clear up the situation, the problem is that they do more damage to the epithelium. Because keep in mind, the respiratory epithelium is not that thick, okay, especially when we get down to the alveolar level. The alveoli is very, very thin. So if we have issue going on there and have a lot of leukocytes and macrophages coming to that area to just try to clean it up, it's actually going to do more harm than good. Okay, so same thing we kind of talked about already. Epithelium damage. So what will happen here is when the epithelium gets damaged, we have, yes, bronchoconstriction that's going on, but when the epithelium gets damaged, it will also go into a state of hypertrophy. So the smooth muscle will get large. Edema, mucus gland hypertrophy, and also mucus in the lumen, which we talked about already. Acute bronchospasm, we also talked about that. Edema, mucus plug, airway remodeling, which means that we have more goblet cells to the airway. So this stuff is just the same thing we talked about. Now, I like this picture because it shows you a nice visual of a normal respiratory epithelium and what happens with a person with asthma. So when you look at the normal respiratory epithelium, we have mucus glands, it's a smooth muscle, everything's nice and neat. And then when we get over here, you look at the lumen is narrow, is constricted, as you can see. And not only constricted and narrow, but it also has mucus in the airway. Okay, so which makes it even more narrow. Increased mucus glands. Yes, we do have a certain amount of mucus glands that's supposed to be here, but with the asthmatic patient, because of the hypersensitivity reaction, we just have now more mucus glands. Also, as you can see, the muscles do get hypertrophy. Okay, they do get enlarged because of this situation that's going on as a compensatory mechanism. And even the cartilage, I think they've even shown you the cartilage is a little larger. So the pathogenesis here, which we've already been over. Okay, so as far as histology is concerned, we already know that this is an immune response that's occurring. So if you were to take a look at, say for example, mucus from a person that has asthma, or take a little sample, you would expect to see obviously a lot of immune cells. Okay. Now, one immune cell I just want to point out to you, because the rest of this we talked about already. One immune cell I want to point out to you is that when we talk about neutrophils, as you stated earlier, eosinophils, and lymphocytes. Now, keep in mind that neutrophils, we already know that neutrophils are there for anything. Okay, whatever type of reaction, bacterial, fungal, viral, whatever type of infection or reaction that's going on in your body, neutrophils are the first ones there. Eosinophils are very important as well because if you remember from anatomy, eosinophils, I believe, had two functions. One function is for inflammatory process, and I forgot what the other function was. But I know eosinophils are secreted with the inflammatory process as far as respiratory, so any type of respiratory conditions. And then lymphocytes are also secreted, and when we talk about lymphocytes, the main lymphocytes I would say would be our macrophages, okay, that are coming to the area. Now, common symptoms of a patient with asthma: wheezing, feeling a tight chest, dyspnea, which is difficulty in breathing, as you can imagine, cough, and they put here dry or productive. So it all depends on how much mucus they're secreting, if they're going to have a productive cough or not. And then the sputum production. So the sputum production, again, depending on how much mucus they're producing, it may be really thick, it may be thin. But one thing that is done with these individuals, if they do have a productive cough, sputum cultures are quite important to do. Okay. And you guys have to look at that. I've never looked at sputum, but I'm sure you will look at it at some point. Okay. Now, the other thing here is that when these patients have a severe attack, or what they call the asthma attack, okay? So what happens here, number one thing is that they use the accessory muscles of respiration. Do you remember from anatomy, what are your accessory muscles of respiration? Say that again. It should be here. Yes. SCM, I think somebody said it, I'm sorry, I couldn't hear. SCM, and what I kind of call it, I know this is not technical, but I kind of call it top breathing. So what will happen here is when a person's trying to do a full exhalation, you know it comes from the diaphragm area, okay? So the diaphragm, your abdominal muscles, okay? And what will happen here is that that's when you get a full exhalation. The problem is that these individuals can't get a full exhalation because they have obstruction in the airway. So they'll try to breathe like that, okay? So they will use their accessory muscles. Intercostal retractions, because again, they're not getting a full exhalation, a full breath. Exhale, not only just exhale, but inhale as well. What will happen is that the intercostal muscles will actually start to retract and go inward. They will have breath sounds or inspiratory wheezing. Another thing, orthopnea, which is shortness of breath while lying down. That shortness of breath while lying down. They put agitation here, which is funny because I think if you can't breathe, anyone would be agitated. Agitation comes from that. Tachypnea, which is going to be increase in breathing, and tachycardia is increase in heart rate. Okay, so all of those things will happen. Now, diagnosis, cough, wheezing, which we talked about already, and hyperinflated chest. Why do you think these individuals have a hyperinflated chest, meaning that the chest wall will just look a little larger? Very good, because of trapped air, okay? Because again, they're not getting a full exhalation, so they will have this trapped air that's sort of inside the lung fields, and so they will have hyperinflated chest, and obviously decrease in breath sounds.
Wait, so you have wheezing and you have decreased breath sounds?
Yeah, so they'll wheeze. The wheezing is like, how can I explain wheezing? Wheezing is breathing. Oh, you have to hear me.
No, I was just saying, isn't the wheezing usually takes place more so on the exhale rather than on the
Right.
inhale?
And the wheezing is not a full, the wheezing is not a full exhalation. It's like a struggled exhalation, so to speak, where the person's trying to have a full exhalation, but it comes out like a. Okay, I know I'm trying to mimic it, but yeah, but you know what I'm saying. It's the wheezing is like them exhaling, but it's not a full exhalation. It's a labored or struggled exhalation.
So for decreased breath sounds, is that the same thing as distant breath sounds?
No, decreased breath sounds is going to be on auscultation. So when you guys are auscultating the lung fields, you won't hear that sort of full inhale, exhale type of thing. That when you hear crackles and all, that's something else if you hear crackles. Distant. Let me go back.
Yeah, that was inspiratory.
Okay, so distant breath sounds, what they mean by that is with inspiratory wheezing, is that when they're inhaling, you'll hear it on auscultation, but it won't sound like a full, I know that term is a little weird. It won't sound like a full sound, if that makes any sense.
So like it's cut short.
Right.
It just sounds off.
Yes, it's going to be off. So even whatever breath sounds you hear with these individuals, it's not going to be a full breath sound. It's going to be small, short, so to speak, halfway, whether they're inhaling or exhaling. And the wheezing is just a term that's used as like not having a full breath, where it's like a troubled breath. Okay, now, this slide here, I would say, try to highlight this as the hallmark of this disease, okay, and I'll explain why in a second. So radiographic findings, if you were to do a chest x-ray of these patients, you will see that the hyperinflation of the chest wall with the flattening of the diaphragm. Now this makes sense because when the diaphragm is flattened, this means that it's flat, it's dropped pretty much too, which means that the lung field, okay, is wider, which means that they have a bunch of trapped air. Keep in mind that if you remember from physiology or anatomy, when the diaphragm is like this, it's at its relaxed state, and that's usually when we're exhaling. Okay, but when you have all the air that's in the lung, that's when it's flat. So, also a sputum examination. So, I've never looked at sputum. Anyone in here worked in the field and looked at sputum before? Okay, well I don't know exactly what it looks like, but you guys will be looking at sputum cultures, and so there's certain things that you will look for. One thing they have here is Sharkin-Linden crystals. Okay, the reason why I told you to also highlight this slide is because usually most standardized tests, they like using these kind of names, you know, Sharkin-Linden crystals and Cushman spirals and things like that. So Sharkin-Linden crystals, this happens when the eosinophils actually start to break down and they start to form like a little crystallized thing. So these when they start to break down, they will break down and start to crystallize. Eosinophils will also be in the sputum. Please keep in mind that these individuals will have a high eosinophil count. Why? Because eosinophils are very important and they're elevated when a person has an allergic reaction, especially respiratory type. And Cushman spirals. Cushman spirals are mucus casts. What does that mean? I know this may sound gross, but say for example if you have mucus and it's out in the air and it's exposed, what is it going to do? It's going to dry. So it's sort of like dry mucus, okay, that can also be secreted from these individuals. So just make sure you know that information there. Now another thing with diagnosing is pulmonary functional testing. So obviously they will go through the whole using the spirometry, okay, and seeing what the pulmonary functional tests are. Now, I'm not going to hold you responsible for this information, but what I do want you to know is that on a whole, pulmonary functional testing will be abnormal. Okay, so just jot that down. But I'm not going to ask you, okay, what is the force FE1 and FEC, because I have to really go over that and explain it, because I'm not sure if you guys went over that in detail in physiology. But in any event, just know that pulmonary functional testing will be abnormal or decreased. So we don't have to worry about this slide here. Now, I have to make a correction with this slide. ABG is going to be arterial blood gas. So what will happen here is that these individuals will have blood work done, okay, to see what their gas levels are inside of their arteries. Okay. Now, I'll tell you a story. I don't know if you guys ever seen this done, but I think the respiratory therapists perform this, if I'm not mistaken. I don't know if the nurses do this anyway. I was having chest pains and I thought I was having, I don't know, a heart attack or something, but it wasn't that. It was just tight muscles because of me working a lot. And if you ever have a patient that has to have their arterial blood gas done, please feel for them. Okay, because the needle is this long, and they put it right here. Okay, and I thought they were trying to get marrow. Okay, they stuck that needle in so far, I didn't understand where they were going. But it's a very painful puncture for some reason. I don't know why they have to go that far. But in any event, the whole point of doing that testing is to see what is the gas level or percentage in the arteries, okay? So I don't know the whole technique and why they go so far, which vessel they're trying to get to, but it is a very long needle, that I do remember. Okay? So in any event, when this test is done, they want to look at the percentage of the oxygen and carbon dioxide, okay? Because this will tell you if these individuals are having issues. I know we know they're having issues with ventilation, but you want to see how much oxygen has decreased in their body, okay, and how much carbon dioxide has elevated. So what happens here in a person with asthma, the arterial blood gas is normal during a mild attack, okay, not so bad, but then as it gets worse, if their asthma is really bad, it will definitely offset the gas levels. So what will happen here is, please cross this out. This is supposed to be respiratory acidosis, not alkalosis, okay, and that's a typo in the PowerPoint. The publisher had an issue with that. So that's supposed to be acidosis. And I think you guys remember from anatomy, from physiology, that anytime you have an increase in carbon dioxide, that will give a person in a state of acidosis, not alkalosis. Okay. So what happens here is these individuals will have respiratory acidosis and hypoxemia. Hypoxemia means decrease in oxygen. Okay, so they will have a decrease in oxygen, along with bronchospasm. And as you can imagine, if the oxygen is decreased, these individuals are going to have an elevation in carbon dioxide. Please understand that they are not having proper ventilation. We already said that they have air that's sort of trapped here. Okay, so they have the hyperinflated chest, so a bunch of air is here, which means they're not exhaling. If you're not exhaling, you're not exhaling carbon dioxide out. So carbon dioxide is staying in the bloodstream and it's causing an elevation, which means they're also having an issue with inhaling, which means that they're not inhaling the proper amount of oxygen that they need, so therefore oxygen levels are low. So the other thing to diagnose, which I went over with you earlier, was skin testing. I don't know if this is standard that they do in the hospital if someone goes in for asthma attack, but if they are under management, I would say, with asthma, it is definitely advised to get skin allergy testing done. And you know, with the allergy testing, they put all the little needles and things on with that. Now, bronchoprovocation testing, what this does, they will give the patients histamine or methylcholine, which is another form of histamine, or like a chemical mediator. And so what will happen here is that they will introduce this chemical mediator in their body, and they're actually eliciting an asthma attack. I know it sounds strange, but that's what it does. It's trying to provoke an asthma attack. So they'll give them the histamine and methylcholine to see if they're going to go through this whole asthma attack reaction, which means it's really testing to see if they have this hypersensitivity. And then the other thing here is on the CBC, yes, with blood work, we know that the white blood cells will be elevated. Eosinophils will also be elevated. Please make sure you know that. That's quite important to know. Eosinophils are elevated with asthmatic patients. Okay. Treatment. So with treatment with these individuals, if they have allergy testing done or know what they're allergic to, avoid the triggers. Stay away from whatever it is, environmental things. I remember patients I know that had asthma. Their asthma was worse in the summer, and so they couldn't be outside.